Hope all of you are imbibing everything what we are having in all our sessions. Like you would have been saying, every session we are telling important. Yes, it's like this 20 session one is like something conglomerated very well, like an A to Z of palliative care. So if it is so, everything is important. And with that note, I welcome Dr. Sanghamitra Bora, who is, as mentioned by Shripriya, an enthusiastic and an energetic person. Okay. And she is the palliative care lead for Assam Cancer Care Foundation. And she has completed her master's from Cardiff University in palliative medicine. And she's also a volunteer in Arujvin Healthcare Foundation. And she's an active teaching faculty in the IEPC since 2010 and a national trainer also in Government of India Health Resource Center. She's very interested in working and delivering palliative care, and she's really a very close friend of Pallium India. She would do anything, I would say, for Pallium. With that, I hand over it to you, Dr. Sanghamitra, to take us through this session. And this session, as mentioned by Sri Priya, is very important because all your queries, what to do, what shall I do, is this right? All those she will answer for you.
Thank you. Thank you so much, Sri Priya. And so glad to see you, Radha ma'am, after such a long time. I think January we met for I think
conference.
2 minutes in the palliative care conference. And today I'm seeing you. The same Radha ma'am. Thank you so much for introducing. It's an honor. Not much.
It's a pleasure also. I have also been waiting to see you. Okay, yeah, really nice.
Thank you so much. Thank you so much. So we'll talk about palliative care ethics today. And I request every one of you to please participate because, unless and until we interact and exchange our views on the kind of cases that I'm going to discuss, we will not be able to, give a better judgment for why we are taking a certain step in a certain case. Okay. So requesting everyone to give your valuable opinions in the chat, as well as, you can actually discuss your concern by unmuting. So not going into much more talking, I would like to share my screen. Can everyone see my screen here?
Yes, we can. If you just go to slideshow mode, that's it. Yes. It's all clear.
Yes, I think that's okay for everyone.
Yes.
So basically, we're going to have a look at the definition of what ethics is about. And we all know about the 4 cardinal principles, but we are going to revisit these principles once again and see where, our work, fits into these principles, and then talk about something which is always and is always going to be an issue with medical practice. So that is euthanasia. So basically, the ethics definition is based on the basics of moral code of behavior. So that is applicable for whatever scenario we face, not only as a physician or as a nurse or as a medical personnel, but also as a, as a person, as a human being. So our behavior will have some kind of code of conduct, okay, which is actually going to have a great impact on what we deliver through our actions or, professionally upon our patients or in the workplace, even when interacting with our colleagues. So basically, ethical principles are a set of principles in a moral account, which should function as an analytical framework that expresses the general values underlying common morality. So this is self-explanatory, and this definition has been given by Bucamp and Childress. And yeah, all our decisions, all our actions in our hospital, in our clinic, in our workplace actually has a background of these ethical principles. So we'll see that the palliative care ethical principles are those of medicine in general. And having said this, we understand that as doctors, we have a dual responsibility. Number one, always to work towards preserving life, saving our patient's life, and at the same time, we will have to see that we are relieving suffering of our patients. So basically, for any doctor, whether he is in palliative care or not, he's practicing any other subject, whether he's in a clinical setup or in a non-clinical setup too, the basic responsibility is to preserve life and to relieve suffering. But in palliative care practice, since we deal with end of life most of the time for our patients, we have to see that the relief of suffering becomes or takes a major work part as preservation of life becomes increasingly impossible. And we need to understand that at the end of life, since the patient is actually leaving this world, leaving us, leaving his family, the preservation of life becomes impossible. But at the same time, our major goal would be to relieve the suffering of this patient. So this is basically the background or the balance that would actually keep us going while we take very important, whether small or large decisions, while taking care of our patients who are in the end of life, and of course, who are purely palliative care patients. So these are the four principles, cardinal principles as applied to palliative care practice. These are basically the patient autonomy, beneficence or non-maleficence, and justice. Patient autonomy basically means what the patients want, and at the same time, does the family of the patient understand his or her preferences? And this is particularly very important when we are dealing with end of life care of a patient. Beneficence deals with our actions or any decision that we take and ask ourselves whether this particular action or treatment is going to benefit the patient or not. And non-maleficence deals with the question of any of our actions, is it going to harm the patient? Are we going to harm the patient, cause more harm to the patient by taking an action, by using a certain kind of a medication? Okay, so non-maleficence deals with, will it harm the patient? And the principle of justice is the fair utilization or allocation of available resources. So I'm going to, bring in some examples, case scenarios in front of you so that we discuss and, debate on what would be the best course of action for this particular patient. Now, why are we so much concerned about ethics? Why do we actually have to discuss this in a different class altogether? That's because of the fact that we know, all these principles, all the 4 principles have crossroads. They intersect each other at one point of a decision. And it actually gives us, throws us actually into a situation where we are unable to decide which principle to give priority to, or which principle should be followed at particular case. And those situations are known as ethical dilemmas. So ethical dilemmas are conflicts of moral principles occurring when a person faces certain situations where adhering to one particular principle might result in the violation of the other. But having said this, we as human beings, as practitioners, will have to find a way out of the dilemmas. And that would depend on our sense of justice, our sense of, deciding on which ethical principle to be followed or given priority at that particular situation. So let us come to examples. This is a person. He's an elderly person, and as you can see in the picture, he has a jaw tumor with a orocutaneous fistula. Now, the doctor says that the patient doesn't have any metastasis. We can actually give him a good amount of treatment, good direction of treatment to improve his condition as well as to improve his quality of life. Now, for that thing to happen, the doctor needs to put him a nasogastric tube or a Ryle's tube. Now, the patient refuses this. What is our stand at this point of time? How do we counsel for the NG tube insertion? What is the situation here? The patient says that I do not want to put in a Ryle's tube. The doctor actually has advised that no, if we cannot put a Ryle's tube, I cannot proceed with my treatment. And we know that he is actually going to be better after taking the treatment. But that's not possible without the patient having to agree to this particular NG tube. Now, can I have some responses, quick responses, so that we can, yes, Shikha, I think Dr. Shikha has raised her hand. Yes, Dr. Shikha.
The thing is, explaining the patient well. If the patient refuses, we can consult somebody from the family or somebody whom he listens. If they can change the opinion of the patient, it is well and fine. Otherwise, we can't actually force the patient to accept our decision about that.
Okay, I take that as one of the options. Okay, anybody else? I think 2 people have also raised their hands. Dr. Parvati Nair has said that speak to the patient and find out the reason for his objection if he's willing to talk about it. Yes, very good. Anybody else who would like to just give us?
In case if the patient is strongly refusing, patient acceptance of treatment is the primary concern. Yeah, the family may be consulted, other people may be consulted, but the patient decision autonomy, which is most important here in this situation.
Absolutely, sir. Thank you so much, doctors, for giving your opinions. When we are talking about this, it's like we are talking about the ethical dilemma. Now, the dilemma here in this particular case is between doing good or benefiting the patient by, putting him on a Riles tube, and the choice of the patient, patient's autonomy. And if we are, trying to prioritize between the two, I think, we are going somewhat with the principle of doing good, because we understand and we are confident that our patient would be benefited when we put him on a Riles tube and start the treatment. So now, what should be the approach to this particular patient? How do we start, justifying the principle of beneficence being superior to the principle of autonomy in this particular case? So what do we do next? Let us understand what patient autonomy is in this particular point of time. Okay, so the patient has to be involved in decision making. That is the underlying point in patient autonomy. Otherwise, if the patient does not know what decision has been taken for him, he will not be able to give his choices. He will not be able to exercise his autonomy to the best of his ability. So when we talk about the patient's involvement in decision making, it has to be the right to have dignity, right to privacy, right to confidentiality, the right to have the right kind of information from the doctors or from the medical team, and the right to make decisions, take his own decisions after, having all the information, right? And last but not the least, the treatment decisions will have to come as an informed choice of the patient. We just cannot ignore the patient, telling us that I don't want a Riles tube, I don't want a Riles tube. It's not possible for us to, it is not only the question of cooperation while putting in the Riles tube, but it is also how, involved he is in taking the Riles tube, accepting that particular measure that we have taken for him. So now, in this particular patient, our approach should be to take an informed refusal. Now, what is an informed refusal? We understand, we have understood, we have come to know that the patient has refused. We have, our junior staff, maybe the nurse who's attending the patient, has counseled him to the best of her ability. And then she told us that no, the patient doesn't want a Riles tube. So what do? We have to take an informed refusal. As one of the doctors have rightly mentioned in the chat, we need to check the understanding of this particular patient as to why this patient is refusing. So, there may be so many reasons of why he is refusing. He might be fearful that, this particular tube is actually going to poke my nose, it's going to go inside my chest, and it's going to hurt me a lot. The fear of having pain. There might be a fear of, bleeding to death, maybe. He might be, thinking that my neighbor who also took a Riles tube didn't get up the next morning. So all these things might be inside his mind playing with his thoughts. Okay. So check the understanding of the patient. what he understands by taking a Ryan's tube, okay? And then explore the reasons. What he understands, and whatever his understanding is, what are the reasons behind this understanding? That understanding might be very true. That understanding might be an ignorant thing. So we need to understand, we need to explore the reasons. And when we know why he is refusing through these two things, these two steps, we will have to counsel. And when we counsel, it doesn't mean that we are giving him some sort of gyan that, no, it is like this, it is like that. No, we will have to, pinpoint the misunderstandings that he has about the Ryle's tube. We have to allay all kind of fear that he is actually getting inside his head, inside his brain. And then try to give him the right kind of information that the Ryle's tube is going to help him, maintain his nutrition while the treatment is processed. And, when we put him on a Ryle's tube, it is actually spare the work of the mouth and give the doctor enough space to heal the fistula or the wound that is troubling him since such a long time. So that is counseling when we talk about counseling in palliative care. And after all these 3 steps, the patient still refuses and you don't know why. Perhaps the patient also doesn't know why he is refusing. But at that point of time also, you will need to support your patient. Okay, support the patient even if you do not agree with the decision of the patient, right? So these are the steps of taking an informed refusal. Now, many of you would actually ask me, so what is the use of supporting the patient even when he is refusing? In my career of these few years that I have had many instances where patients have refused to take, Ryle's tubes, even when we have actually followed all the 3 steps. But then the 4th step of supporting the patient actually is a game changer, because the patient now understands that I refused, still this person, this doctor is my friend. He wants me to be well. And you will see, you will experience that after maybe 2 or 3 days, even after a week, he actually comes back to you and says that, okay, doctor, I have understood what you're telling me. I believe that I'll be better if I take a Ryle's tube. So, this process may not be within 1 hour or a day or within your duty hours. It might take some time for this patient to understand, to comprehend what is going to happen, except that, he has to take it, or, there is some kind of a stagnation because of his refusal. And when he understands, he comes back to you, you give him a Ryle's tube, you start his treatment, and you see the change. So, autonomy, and you are successful in, benefiting the patient through this particular action. So this is how you manage, this is an example of how you actually prioritize one particular ethical principle over the other. So I just want to draw your attention to another similar kind of a case. So this particular 20-year-old boy has a osteosarcoma of the lower end of the femur. And as you can see, the whole tumor is a huge one. At the same time, the patient has multiple lung metastases. It has spread to the lungs. And since osteosarcoma is, it brings with it the complication of anemia, the patient is also suffering from severe anemia. But the patient wants an amputation. He says that, please cut off my leg so that I get rid of this tumor. And, I don't want to see my swollen leg like this. I just can't stay with it. Now you've explained the risks of, this amputation of this particular leg, but still he wants to continue with the amputation. So if anybody could give me some bit of advice on how we should be approaching this particular patient. Anybody who can just give me 1 or 2 sentences. Yeah. Anyone?
Considering his age, although he has multiple metastases, maybe the quality of life will be much better without the tumor, with his this thing. At least whatever is this thing, he'll be much better able to take part in his day-to-day activities. So I think we should give a benefit of this thing to him and his option of getting the amputation done, and maybe follow it up with, because osteosarcoma, all the lung metastases are there. Take care with other chemotherapy or radiotherapy, and he should benefit from that once the primary source is taken off.
So, sir, I would like to ask you one simple question. Are you confident that if we put him on the OT table and we start operating, a patient with severe anemia, a patient with perhaps very less space of exchange of oxygen, do you think that this particular patient would be coming out of the OT?
Yeah, he should see. It's not that he decides for a surgery, he goes in immediately for the surgery. There will be some time where with transfusion he can be optimized and taken up. Maybe it's not that we can't wait too long because already he has lung metastasis. Yes, if the consideration is only for anemia, with transfusion it can be managed, build him up and take him up for subsequently for surgery. He should, considering the age when there are no other comorbidities like the elderly people, he should definitely do well. At least the quality of life should be much better. That's what my opinion is. Hello? Hello? Am I audible, Grace?
You are audible.
Yeah.
Maybe
Suddenly,
madam.
I was not getting any response. I thought whether I...
No, madam might have. I think she
I
is.
think we lost her. Video part.
That's what you were audible, sir. We could hear you.
Thank you, madam.
Anu, can we just pause the recording for a moment?
Hello?
Were you able to hear?
Yeah. I think I lost my connection. I'm sorry.
No,
I'm sorry, I lost
hear
my connection.
what he said completely?
No, I didn't actually.
So if you don't mind, can you repeat, please?
Yeah, but definitely. This, my opinion is, considering his age, it does not have any major comorbidities like an elderly person, like hypertension or cardiac disease or anything. Yes, we have some limited time where his anemia can be optimized and a surgical option can be given to him he should definitely do well. At least the quality of life should be much better without the tumor burden. That's my feeling.
Okay, so I first and the foremost, I think let us, I just want you to concentrate, focus on the case history, which says that he has a large tumor, he has multiple lung metastasis, he has severe anemia, and we have been told as palliative physicians, we have been told that this person is not going to make it out of the OT. You know, the surgeon is actually refused to operate on him because the procedure is too risky considering his general condition. Okay, this is the scenario that we have. We can keep on actually, debating on the fact that we should be operating on him. The point that I want you to understand is that the surgeon has actually refused to operate on him, considering the risk that is involved. Do you actually understanding? Are you understanding what I'm trying to say? Yeah.
If the surgeon is refusing, then that will be a different
Yes.
option. This is a different option.
our-
Then we need to consider for palliation only.
Absolutely. So that is what, like now, the case is that the surgeon has refused. The surgery team has refused to operate on him, but the boy actually told you, because you were on the rounds, you are on the supportive care team, palliative care team, the boy actually comes to you and tells you that I want an operation done. The surgeon has refused to, but I want an operation to be done. So what will be your take? Because you have to abide by the, you can't just force the surgeon to take his decision, right? The surgeon is taking his decision. The surgeon has actually told you about his decision of not going to be operated. Now, what is your take on this? That is what I want to know. All right. So the point here is, we know that we want to avoid any kind of harm to this patient. Okay. We also understand that the person wants a surgery, the boy wants a surgery, and there will be a dilemma between how to do good and how to avoid the harm. Okay. So henceforth, what do we do here? What is the approach in this particular patient? Now, we have to understand what are his chances of cure. We already have understood, we already know that the surgeon or the surgery team has refused to operate on this patient. Okay. And so our homework will be to work it out with the surgeon and find out what are the chances of cure. The surgeon has his own, reasons of not operating. So our question to him, and of course to us, will be, what are his chances of cure when we operate on him or when we do not operate on him? Secondly, if at all we go by the wish of this patient and decide on to take him for a surgery, will he survive that surgery? It is definitely a major decision. It is going to be a major surgery. We know osteosarcoma to be a very, very heterogeneous body. There'll be a huge lot of blood loss. At the same time, he has complete metastasis of the lungs, which is again going to cause a lot of problems during the surgery. So is he really going to survive if we try and operate on him? And then suppose he survives, if he survives at all, will the amputation improve his condition? We can keep on trying chemotherapies, we can keep on trying radiotherapies, but we must be clear about what the goal is. What are we going to achieve? Are we actually making this person deteriorate on his present quality of life? Are we going to push him towards a situation where he is actually unconscious all the time and trying to swim across the vast kind of a situation that we have made him fall into? So these are the questions that we will have to answer to ourselves first, and then perhaps give those answers to our patient. And when you talk to him about these particular questions, the patient will actually really not want to go for a surgery. Okay. I know there'll be a lot of other questions. We'll definitely take them at the end, but I'm coming to a similar dilemma where this is a 20-year-old boy. He has an advanced cancer, some kind of advanced cancer under your care. Okay. He's been actually transferred to palliative care. So it's under your care. This patient is under your care. Unfortunately, the patient does not know anything about the diagnosis and the prognosis. And the relatives have actually insisted that any issue related to the diagnosis and prognosis should not be discussed with him. So when you go to see him one day, he's alone in the ward and he takes a chance and asks you what is wrong with him. So what are you going to tell him? The relatives have already told you, insisted that he must not know about his diagnosis and there should not be any kind of discussion regarding the prognosis also. So you tell me, how are you going to handle this situation, or what are you going to tell this boy when he asks you that what is wrong with him? And any inputs? Yes, Dr. Parvati.
Yeah,
Yeah.
hello. So having been not personally in a situation like this myself, but my mom's best friend was in the situation. I might be a little biased, so I feel a little strongly, but this is a 20-year-old boy. One presumes that he's competent, and if he's competent, in my opinion, withholding information about diagnosis and prognosis is wrong. However, you can't just without anything drop it on someone saying you have cancer and this is terminal and that's it. You first try and understand how much this person knows, because usually they do have some idea, because they've if you're this old and if you have a diagnosis which is this serious, you know what's happening to you, and from there slowly build on it. And at the same time, you don't as I said, you don't reveal everything in one day. You talk to the patient, talk to the relatives, and slowly bring them to a point where the patient is aware, because it's just wrong that a person doesn't have the ability to make their final decisions and put things in order before they pass away.
Absolutely, Dr. Parvati, that's a very excellent, pertinent explanation. And I completely agree with whatever, whatever point you have actually put in. So definitely a 20-year-old boy is an adult for us. He understands what is going on. He also understands, what might happen. Maybe, he understands more than we can presume, we can think. And, when we talk about the relatives who have insisted, now, I'm a mother, I have a 18-year-old son. And as a mother, I'm always protective about my son. Okay. I still think that he's a 5-year-old kid. So the relatives here, whether they are his parents or his uncle or, auntie or whoever, they are actually, they are not wanting him to know about this, because they feel, or, they are sure that once they give them this whole thing about having cancer and, perhaps in the last stage of this cancer, he'll be the one who's going to be hurt like anything. So they do not want this boy to be hurt. They do not want him to, they just want that he should be protected from any kind of bad news. Okay. So this is their, what to say, maybe a version that they have with them. Okay. So the point here is, are we, is it really right to deliberately mislead the person or a patient, or to withhold information that the person is asking for at the insistence of the patient's relatives? And as Dr. Parvati rightly said, we need to take, turns of actually talking to the patient separately and talking to the relatives also. They may actually think that we haven't told him anything. We have asked the doctor not to reveal anything, so he doesn't know. That is what the relatives think, but it's actually not like that. We need to, show them, or, we need to give that importance of the conspiracy of darkness. That is actually the conspiracy of silence that is between the patient's relatives and the patient. Okay, so that particular scenario would actually bring them closer together. Maybe we will have to create a bridge between them and the patient and facilitate a communication where there are no curtains, between the two. And you will not be surprised to know that the patient has accepted what is happening to him, and he already knows much of it. Okay, so here, the importance of the principle of maleficence, and the principle of patient autonomy also actually comes into play. All right. So we will have to depend much on our communication skills to actually bring both the parties together on one platform, remove all the curtains, all the misunderstandings, between them, and then perhaps, facilitate a more constructive kind of a uniform constructive kind of a behavior between the two, where the patient's relatives no longer feel insecure about sharing the prognosis of patient's condition, in the coming days. All right. So this is about this particular case, and if the time is not too long, then maybe okay. Shripriya, it's 5:45. What time do we have the case presentation? How much time do I have?
Ma'am, maybe you can take 5 to 10 minutes if it is okay with everyone. 5
She
to
can
10
go
minutes.
ahead.
Yeah.
Because till another 10 minutes at least, because we'll have time for your discussion and the case discussion. 5-10 minutes you can take, Sanghamitra.
Okay. So maybe I'll just skip on these things because I'm going to share it with you. All right, so I'll just come to the principle of justice here, and perhaps justice is one thing that will always be a principle that will always put us in a situation which will actually make us feel really very bad when it comes to barring a patient to get some kind of a treatment, okay, because it's not there with us. Many of us have an experience of have worked in government setups where we really do not have very simple injections or tablets to give, okay. We have something in stock, and we have to give that away to a patient who needs it more, but then ask the other patient who has not got that particular medication to go and buy it from somewhere else. Or there is a situation where there is just one bed, there are two serious patients, and we have to prioritize which patient should actually get the bed. So we've all gone through these kind of situations in life, and that becomes a kind of a very bad situation when we need to justify why we are allocating certain resources. So this is Mr. SS, who is a war correspondent, and he's 86-year-old. He has lung cancer with metastasis to spine, the ribs, the sacrum. He has a son who's a psychiatric patient. He has 6 grandchildren. Now the goals of care that we have decided for him are the pain, the family finances, Janavya Sanskar that this particular patient is wanting to do for his grandsons. At the same time, since the cancer is actually deteriorating, his breathlessness is also apparently increasing. Now, should we consider an ICU admission for this patient? Are we actually going to give him this particular benefit, by putting him in the ICU bed, which might be actually useful for a young patient who might actually land up in our emergency with a head injury, So this particular situations become a little dicey, where we will have to justify why we have given admission to a patient who is young, has had a head injury, and why we have not allocated this ICU admission to this particular person who is actually going to die. So fair utilization of resources would actually question us on the utilization of the family's resources, fair allocation of the hospital resources, the resources of the society, the resources of the nation as a whole. Okay. So quickly, I would touch upon this particular point of euthanasia, which is, always surrounded by ethical principles, ethical dilemmas all the time. So euthanasia generally is an act or procedure in which someone takes active means such as lethal injection to bring about someone's death. And when we say that we are allowing natural deaths to occur by withholding or withdrawing a futile treatment, it does not amount to euthanasia. Okay, this is something that we have to understand. Okay, when we allow natural death of a person to happen, okay, by withholding some process like, ventilation, we are withholding that particular process, particular measure, or we are withdrawing a futile treatment. For example, an ongoing chemotherapy for a person who has multiple metastasis, and is going to apparently, we have actually diagnosed this patient in an end of life, okay? And still the patient is being given chemotherapy. So we are actually going to withdraw this particular futile treatment of chemotherapy, and we are allowing natural death to take over this patient. It actually doesn't mean that we are euthanizing the patient, okay? It is not that. So this particular second point, I really request everyone to please keep this in mind, and then decide whether you are right or wrong in allowing natural deaths to occur. Now, in IPC section 88, we have a legal provision of, allowing natural deaths to occur by withholding ventilation or any kind of treatment, or withdrawing some kind of futile treatments. But unfortunately, still this has not, we do not have any kind of practical implication, practical, practice that has been done through this particular provision. So what has happened is that, in January 2023, the Association of Critical Care Medicine and IAPC had actually, they have been working all together to bring into advanced directives where this particular legal provision could be exercised for our patients. And withholding and withdrawing treatment has been explained in a much better way, and advanced directives are now, they have a system where every hospital, would have a very simple procedure of following a patient's advanced directives. So it's the paper is there in Indian Journal of Palliative Care. I would urge everybody to go and have a look at that. They have very beautifully explained all the legal provisions that is there for us to follow, so that, we are not actually pushing our patients into unnecessary mechanical ventilation. Something, that always is disturbing for us as physicians, and it's very, very dissatisfying for people, is the point of futile care. So when you know that your treatment or some kind of a measure that is being given to the patient is not yielding anything, and it's been, it's going on and on for a long period of time without any kind of yield, without any kind of positive result, that this particular care is futile. So the AMA Code of Medical Ethics has actually very beautifully delineated that physicians are not ethically obligated to deliver care that, in their best professional judgment, will not have a reasonable chance of benefiting their patients. So always keep this thing in mind, that you, being a physician, you are not ethically obligated to deliver any kind of care which is against your best professional judgment, and that particular care will not have any kind of chance of benefiting your patient. Okay, so do not take any obligation, then, oh my God, I have to do it. It's not like that. All right. So unfortunately, even when we know this, even when we have been taught about futile care, why do we actually get inclined to go for futile care? And the problem here is that physicians are oriented to curative care only. Okay. We have always been taught about curing our patients at any cost. Okay. All our hospitals today, it's not only India, it's worldwide. Physicians and hospitals and healthcare organizations are always oriented to palliative, curative treatment. Okay. But palliative care is a very welcoming change because it helps us to accept. Shri Priya, I'm just taking this call. Excuse me for one moment, please.
Sure.
Generally, physicians do not have any training in palliative care, and palliative care generally makes us accept the fact that it's not always possible to cure somebody of the disease. Okay, we need to have a holistic approach. That is a different thing altogether. But accepting ourselves that we are human beings and not gods, and we are not able to cure our patients is another one kind of acceptance that we need to have. And of course, there's always a fear of being blamed for suboptimal treatment. For example, okay, she didn't give me these particular vitamins, but then he gave me, and my patient was better the next day. So this is something, there is a fear always in a doctor's mind that I will be blamed for not giving the optimum kind of treatment. And then ignorance about the guidelines for end-of-life care. So these are very recent changes, definitely, that I have to say. But then we do have guidelines for end-of-life care. And, the question of euthanasia that always revolves around us for any kind of problem, it's when I was an intern, I used to hear that whatever happens, if you feel that you are not able to handle, this was the phrase: if you're not able to handle, shift the patient to the ICU. So these things are some kind of fears that are that are ingrained into us because of certain practices that came into existence because of the reactions of family members, because of the communication gap that started coming in between patients, between the families of patients and the medical staff. So this is the guideline that I was talking about, and I would urge everybody to please go and have a look at it. You have a proper 12-step guideline, a 12-step policy where you can go step by step when and how you're going to actually execute the end of life care for a patient who is going to leave you, who has a prognosis of maybe around 6 to 7 months. So there is a difference between killing and letting die. Okay, there is a moral distinction, and you can actually think that I am going to kill this person. I am going to let this patient die, but then you cannot judge yourself that you are killing this person. So I'll give you an example here. For example, if there is a patient who's in severe pain and has been suffering since a long time, the family members actually, plead you to give him some injection that is that is going to make him, feel a little better. But then, that while you give this injection, the patient might actually die also. Now, if you advise this particular patient, if you decide that I am going to give this injection to this patient, and this patient might actually die after giving this injection, your intention is actually not killing the patient. Your intention is to bring relief to this particular patient. Okay. But if the family member says that, I want my patient to die because he's been lying there since such a long time, okay, and I am unable to take care of my patient. So please give him an injection which is going to make him sleep forever. Okay. He's not using the word kill or something, but then he's using the words that it's going to, my patient would sleep forever. So here that your intention of giving this particular injection is, going to have a lethal effect. Yeah, definitely your intention is not to, curb any kind of suffering, physical suffering, but to end the life of the patient. So this is the distinction between killing and letting die. So euthanasia, as we have understood, is that particular lethal injection that you intend to give to this patient to bring about death for this patient. Okay. And, by bringing about death of this patient, you are at the same time giving relief to the intractable suffering. Whereas, when we withdraw or withhold a certain kind of certain kind of a treatment or measure, and at the same time we take a measure which actually is intended to relieve the intractable suffering, but at the same time has an intensity to cause or bring about the death of a patient, will not be counted as euthanasia. Okay, so it is the intention that you need to understand. When your intention is to put the patient to sleep, irrespective of the fact that he can be relieved of his suffering, okay, then definitely it is euthanasia. So you are actively taking one measure to put an end to the life of this patient and henceforth relieving the intractable suffering, will definitely be active euthanasia. So understand the fact that there is nothing called passive euthanasia. Euthanasia will always be active. You are taking a decision. You are giving the patient intentionally something which is bringing about death of this patient. Okay. So that particular decision is causing active euthanasia. It has to be active. It cannot be passive. So do not resuscitate. I've already spoken some bit about it. So not resuscitating a patient doesn't amount to euthanasia at all. Okay. You are not fighting death. That doesn't mean that you are causing death. Okay. So questions like, using oral morphine or IV morphine and other drugs to relieve pain, will it cause euthanasia? It will not. When we stop treatment, when the burdens outweigh the benefits, is this going to be called as euthanasia? Not at all. And when we allow nature to take its own course and allow natural deaths to occur for a person, that is also not euthanasia. Please read this particular book by Atul Gawande. It's a lovely, lovely book. He has explained with a lot of examples about, end of life, about withholding treatment. There are many things that can be, you can actually relate to what he is trying to explain through his experiences in this particular book. And of course, we really cannot afford to die in the ICU for so many reasons. And, the most important being that 85% of our healthcare spending is out of pocket. 39 million Indians are, becoming poorer year by year due to rising healthcare costs. And, most of our deaths are related to aggressive medical interventions at the end of life. And, this 300% increase in inpatient expenditure has been seen in the last 10 years. So palliative care is, trying to reverse this by actually by bringing in home-based palliative care for our patients. So this is our take-home message, that need to apply our ethical principles against a background of respect for life, accepting the ultimate inevitability of death. And palliative care practice actually, makes a doctor, a physician, more prone to accept the reality of, not being able to cure at all the times, but definitely, a sense of care that needs to be given to all our patients, whether the patient is in a first stage of any terminal illness or at the end of life. So I end my presentation here today, and I'm going to share this PPT with everyone, with Shri Priya. She's going to send you some of the slides that I was not able to explain because of time shortage, but they are all very, very self-explanatory, and they're very simple. You'll be able to understand when you go through them. So thank you so much for your patient hearing.
Thank you very, very much, Sanghamitra. You have taken us through in such detail. Before, there are a few questions in the chat box which I wanted to ask you. Before going into anything, I just thought you have put it crystal clear, the difference. I just want to tell one thing. No one should have see, if something is possible, like correct the correctable, whatever can be done, we will do 200% to correct it. Okay, this is something all of you should take from this before we go into the discussion itself. So if something is possible, something can be changed, we will put heart and soul and do it. Okay, but also there are situations where that state is not there. Okay, that is where understanding is needed, and that's a medical decision. This is something you have to take. It's not one man's decision. Okay, there are so many papers, so many information, data available telling that 80% mortality happens if this is the condition. So it's not I decision, me decision, or one person's decision in those states. Okay, it's a collective medical decision which says that it's not possible, success is not possible, futility is expressed. That is where all this come into play. Okay, so that is what first thing I wanted to tell, that good we will do, but at the same time not possible, we will not do more harm. Okay, risk benefit ratio. And next, reading, kind request to read this book on Being Mortal by Atul Gawande. I have been telling this for the last few years. I've God's grace, I've had the opportunity to see the surgeon also. He's an excellent person. He was awarded once in Hong Kong when I had the opportunity to see him, because he has also been, he himself is a surgeon. He was running a program called Saving Lives, where best, basic facilities have to be there. He ran that program all over the globe to make sure that any surgery happens, minimal basic standards are protected. Okay, so like that book opens your eyes, like what is cure, care, everything. He starts off how we all do medicine, not knowing clearly only is cure only the job of us, or care also is our job. So like that's another thing worthwhile reading. Now let us go into the questions for a few minutes, which were in the chat, Sanghamitra. One was regarding any general NG tube placement, do we need to get informed consent? And that I think you have explained based on the case you have to do. And then another thing was regarding the second, that orthopedic boy, where surgeon had refused. Someone had put, why don't you ask another surgeon to operate? Is that right? Just let me check that.
Yeah, I think
we need another a surgeon to agree to do ask another surgeon. I didn't understand. I think it was Parvati Nair, I think.
yeah.
Do you mean that you ask somebody else to come and operate when one person has refused? If you don't mind, you unmute and please ask your question, dear.
Yes.
We had asked for our opinions, and at that point of time, it was not clear that whether the surgeon was agreeing or not. So my concern was that you promise a patient that you will do something, and then you don't have anyone to operate, then they lose trust also. So that's also an issue which comes in. So until we are sure that we can get a surgeon to operate, we don't commit one way or the other.
Yeah,
No, but
I completely agree, Dr. Parvati. This is also a very common scenario actually, and people, patients and their relatives actually misunderstand. That is where I said the fear of providing with optimal treatment, suboptimal treatment. So in cancer, it is very pertinent that you yourself ask your patients and your relatives, the patient's relatives, to seek for a second opinion. There is a huge load of evidence in the literature where there's a very it's very important for everybody to refer their patient to a fellow colleague, who has his own sort of opinion about the condition of the patient. Okay, so that's a very good point, and I really agree with that, because you did promise the patient that, okay, I'm going to do something about it. Let me just check. And if you can find somebody, some senior person, or a person or a doctor who's practicing in another super specialty hospital, just come and have a look at this patient and talk to the relatives. I think that is also a very important gesture for this particular patient, because of one fact that we are sure of, that this surgeon is also going to give the same kind of an opinion. It is very, very rare that a second opinion generally differs from the first, unless and until you really do not know what has happened in the past. So I think that's a very good point, ma'am. Yeah, thank you so much, Dr. Rao.
Thank you, Sanghamitra. And then to Dr. Sanup Kumar, he has mentioned withholding ventilator or ECMO, it's a passive euthanasia. Do you still say so, Dr. Sanup, after listening to all what she said? In that case, you could, and he has also mentioned his American Medical Association medical code accepted in India. Those two, I would ask Sanghamitra to answer, please.
Yeah, ma'am. Yeah. So, Dr. Dr. Sanup, maybe you can actually go into the details of the ICMR, euthanasia objective that they have actually laid down. There is a paper which is available with Sri Priya directly from the ICMR, and you can have a look at those. Those actually give. Yes, so you went through the 2018 guidelines, given as passive and active. Absolutely, yes. And that is something that we are still fighting with the, I think Dr. Rajagopal sir is also taking, has always taken the lead of bringing this thing into the right perspective of the passive and active euthanasia. And we need to tell the court that there's nothing called passive euthanasia. So I think we are still in the process, and maybe one day we'll be able to make them understand. And thankfully, this is actually coming into settlement because of the advanced directives that have been laid down and simplified in January this year. Okay, so this is paving a way to actually give us a proper definition of euthanasia for Indian standards. All right. So hopefully in the next 1 or 2 years, I don't know, I can't say, I'm a very small person here, but then hopefully we'll have something in place. 2018 guidelines are actually the ICMR guidelines, and there are certain examples that have been given also. But having said this, I think ICMR is also looking into how euthanasia can be properly laid down so that we do not really have, passive active things going on. Yeah, that's about it. Yeah. Yes, Sri Priya has already shared.
Yes, Sri Priya has shared the document. And also, as Dr. Sanghamitra mentioned, this January thing is, if you don't mind, Dr. Sanup, this latest January 2023, you would have to see. And we have another session on end-of-life care in which you will be explained a little bit more on detail on that also.
Yes, absolutely, absolutely.
Guidelines, and then that will also help. And because withholding and withdrawing treatment is entirely a different thing.
Yes.
I would not want anyone to confuse that with euthanasia at all. Please, please, please. Okay, they are totally different. That's why you have to understand what it is. Go through all these information, and then if you all have any doubts, then I would say wait for that end-of-life cases session. Okay, because in that also more information and more knowledge gaining information you will able to hear. You will be able to hear. After that, if someone still has doubt, then get back. Okay, now we'll go on to the case discussion. I think Sri Priya, I'll hand it over to you, please.
Dr. Swami?
Thank you, Sri Priya and Madam Radha and everyone. I'm just going to, since I'm dealing with neurocritical care, I'm going to present a patient with neurocritical care illness. We had recently had a patient with 87-year-old lady presented to a hospital with left middle cerebral artery infarction and with associated atrial fibrillation. Can we have the next one, please? Yeah, she had sudden onset of weakness, right upper limb and lower limb, drooping of the face with drooling of saliva. There is no history of associated loss of consciousness or involuntary movement of limbs. Within about 24 hours of admission, her sensorium worsened. She deteriorated to a Glasgow scale of E2, V2M4, that is eye opening only to pain, or sometimes no eye opening also, incomprehensible sounds, and only friction to pain on the left side. Past history, she had an old right cerebellar infarction about 6 years ago, from which she had recovered. She is also known diabetic and hypertensive, about 30 years on treatment. She was not on any treatment for atrial fibrillation, although which was diagnosed in association with the right cerebellar infarction. Due to the gait in the unsteadiness, she had a fracture of the right hip, but the surgery at that time surgery was not offered because of the various other problems. And following the fracture of the right hip, she has always been bedbound. Clinically, on examination, she opening eyes to pain or occasionally spontaneously making some incomprehensible sounds, moving the left side limbs to pain. Her heart rate was 110 per minute, irregular. Blood pressure 160 by 90 millimeters of mercury. The respiratory examination revealed bilateral conducted sounds. This is the most important. ECG or MRI done on admission showed a large left MCA stroke, old right cerebellar infarction, total occlusion of the left internal carotid artery. ECG revealed atrial fibrillation with fast ventricular rate. Echo showed there's no evidence of intracardiac thrombus or vegetation. Left ventricular ejection fraction was reduced to around 25 to 30% at the when she had the clinical deterioration, CT scan repeated showed a worsening of edema, midline shift of about 1.5 centimeters, and impending herniation, ankle herniation. So treatment was for any patient with stroke was offered to her. Following the deterioration, she was referred to neurosurgery and was also referred to the intensive care unit for the possible intubation and mechanical ventilation. The surgeon, however, refused to operate or refused to offer the surgical option because in view of the advanced stage, previously bedbound status, poor cardiac risk, and the various other comorbidities of the patient. Now, next one, please. Yeah. So at this time, there was a family meeting which was conducted with the children of the patient because as this lady was a widow, there's a split opinion for sure among the children, whether to shift to the ICU and for further management and also for surgical intervention. Some of the children were for surgical intervention and to shifting to the ICU, but they were not, some were not against the any further aggressive management. So the concerns are, what I would like to say is, what are the options now, whether to shift to the ICU because of the split opinion and the patient herself is unconscious and unable to give a decision herself what is to be done. ICU shifting and whether to go ahead with intubation and mechanical ventilation when surgery is not being offered. Is it valid for us to refuse treatment or to go ahead with the family members, some of the family, along with the family members who are for the treatment? So in summary, it's a 87-year-old mother of 6 children admitted with a large left MCA stroke with clinical deterioration, multiple comorbidities, bedbound, and split decision among the family members for aggressive management, whether it's for ICU care or for surgery. Yes, please. So what I would like to discuss is what are the ethical issues in view of the split opinion? What should be the extent of treatment to be offered or the ceiling of care? How do we establish it? Can we consider with this patient to establish a do not attempt resuscitation? And what will be the option, suppose before the family decision takes place or before any specific treatment is established, if the patient further deteriorates, what should be the role of the clinician in this case? Thank you.
Thank you, doctor, for presenting this case. Before starting anything, after having this session, see, you have done the presentation. What is your opinion itself after having the session? And if you don't mind, can you tell, you said you work in a neurocenter. May I know what specialty you belong to?
I'm a neurocritical care, madam.
You're a neurocritical care physician, right?
Yes, please. Yes, please.
Okay. And your institution, is it a government institution or a private institution?
This is a government institution only. This is a government institution.
Okay, thank you very much. So if you would want to just, as I asked, no, you before you send this presentation for today, and now after having had the session, what is your opinion itself? What is that you would have done differently to what you have done? It's just a open discussion, doctor. There's no fault finding, nothing like that in this. Okay.
Yeah, definitely.
So if you don't mind, do you want to take us through what would be your opinion? Sanghamitra, hope you're okay with what I'm asking you. You are most welcome to stop and go ahead with whatever you would like to do, Sanghamitra.
No, ma'am, absolutely. I think this is the best place where everybody can discuss their own, because they've already gone through the session, and now they are, in a position to actually give their decisions. And
so that's why I just thank you.
Absolutely, absolutely.
Thank you. Go ahead, sir.
Yeah, so my option would be actually have again a discussion with the patient, since patient is, of course, clinically unstable. Have a discussion, explain to them, because the what I would like to say, because she is bedbound, it's not going to anyway improve the quality of life for the patient, whether it's going ahead with intubation and ventilation. Maybe yes, if surgery would have been offered, there would have been a different concern, because maybe with a decompression, she may improve to a pre-morbid status. Now, since surgery is not being offered, so I would like to convince the family for a palliative care and maybe more of a supportive treatment, rather than going and shifting the patient to the intensive care unit, intubating, ventilating, and going through the whole process of prolonging the hospital stay for the patient. This is my this thing. And
thank you very much. See,
and definitely yes,
go ahead.
And one more thing regarding the DNR, definitely when having the family discussion, I would mention about that, because because when I'm trying to tell them I'm not offering a ICU care, DNR, do not attempt resuscitation also becomes a part of it, because when we attempt resuscitation, we need to intubate or consider ventilation for the patient. So when you are not considering ICU care for the patient, then DNR becomes a part of this thing, which I need to explain to them at that moment only. This is my take, madam.
Exactly. Thank you very much. See, that is what the going through these sessions do, isn't it? So really, really important. First thing is that explaining to them. See, only trouble is that they are having different opinions, but that's their issue. Okay. We need not go into why they are having that. Our duty is to explain these goals of care. See, she's been bedbound for 4 years. Okay. Yes, goals of care should have been put in place before this admission. Already time lost, golden time lost, I would say. Whoever yes, has been seeing, see, that is what you anticipate some things. You have to see when you're seeing some patient like this. See, ABC, take system wise. Every system, she's got some issue. Okay, ejection fraction 30%, you're telling, and already, yes, and your MRI findings are like what to say, they are literally blaring, our eyes showing everything already, and complete carotid block. Okay, yes, with all that, in the surgeon refusing stage is secondary. With all that, will she have a better outcome?
Yeah, that's what. That is, I would be considering that, and taking the further decision that not to offer on any aggressive management, rather than comfort care.
Exactly. So only thing what we have to, the biggest barrier or biggest difficulty what we face is not that we are not going to do anything for him. That is what is the difference between this and even withholding. You give assurance to the family that you will do supportive care, complete total supportive care will be done, not that nothing will be done. We will, yes, be there to help her, to keep her comfortable and give the same dignity for her. Treatment is not the only option. So main thing, talking more to the family, explaining to them, explaining to her, will she be better off? She came bedbound. What is that? Is that she can become better off than that?
Yeah.
So those type of explanation, and then regarding DNR, you have already explained. And when further management, like further active interventional management is not there, then DNR is hidden within that itself, that it's already understood and it is there. So that is quite obvious, but we may have to explain. So this is where explaining to the patient and family about goals of care is very important. And that's all. So system wise, you see, and then if, as I said, no, if these things were explained to the patient, and in all these cannot happen in one consultation or one meeting, it will take, that is why this 3-4 years, when you have this chronically ill patients, you start totally slightly telling to them when they, all that will be taken in detail in your end of life care. I don't want to spoil the benefit and interest of that session. Okay, so it will be taken. And so thank you very much. So you yourself understood and you did this. I did not do anything. See, you going through the session threw light on you to take a wise and best decision for the patient. Always see, even in these situations, patient is we are doing everything in the patient's best interest. Okay, so giving important, and you cannot stop the inevitable. Okay, those are things. Okay, Sanghamitra, I would just ask you to.
I think we need to assure them of comfort care to the family.
Exactly.
That's what
That's
makes
what I
the
said,
difference.
no?
That is what makes the
Tell
difference.
them not, we are not abandoning you because we are not going to do ICU and surgery. That doesn't mean there is another path which can be taken, and in that she can be taken care of. All symptoms will be taken care of. Whatever that sort symptomatic care is, what is palliative care? You're taking away the suffering, we'll give pain relief, we'll make sure everything, nursing care, medical care, everything will be continued. That assurance is important. And all this, no, you have few more sessions, you'll know a lot in communication and end of life care about this in more detail. Okay, Sanghamitra, I will hand it over to you to take us through, Sanghamitra.
Thank you, madam.
Yes, ma'am. Dr. Swami, excellent explanation, and I'm really happy that your thoughts and my thoughts and madam's thoughts we are all in the same plane. That's very really overwhelming for me. Thank you so much. But I want I want to understand one more fact from you. The last point that you have given here, if before discussion from the decision from the family, the patient deteriorates, what should be the clinician's role? I want to understand your or anybody else who is interested here to know their view on this particular point.
My concern, why I told is because on the first instance, when the family meeting was there's a split opinion between the family whether to go ahead with the shift to the ICU or withhold the shift to the ICU. Okay, so when we are contemplating for more family meeting discussions, which may not take place in continuity, maybe subsequently, maybe after a couple of hours or after a day or two or whatever it is. In between, if there's a patient deterioration in the condition, because before any of this ceiling of care or DNR or anything is established, how do we go about it? Because see, that is the situation, pressure situation where we tell the family something or how to convince the family at that particular point of time, especially when they have a split opinion. This is what I wanted to be discussed.
Okay, so I agree with your view, Dr. Swami. Only thing that I want to add to whatever you have said is that prognostication is a great tool that we have. Okay?
Yes, ma'am.
So when you when you prognosticate timely, I think that makes your discussions with the family much more fruitful and much more goal oriented. Okay, so I would urge everyone out here to prognosticate your patients, whether they're in the ICU, whether they're in the ward, whether they are, cancer patients, or, they are advanced end stage disease. I think you have to prognosticate your patients very, very timely. And if you do that, you already have your homework done and you know what to tell the family members. Okay, that becomes a great guidance for the family to come out of the confusion that they have been having regarding the patient's condition. And that is a kind of, facilitating the family to take the right kind of decision for this particular patient. Okay, they will actually not have a split opinion when you give your prognostication to the best of your ability. All right. So I would really urge everyone to, try and practice prognostication, because that is also a science. It cannot be, bhavishya vani nahi hai. It is not a foretelling things. It is purely on science, purely on the the symptoms and signs that we are seeing for the patient. And that will definitely come by practice. So it has helped me in my, practice also. And that is the reason why I am actually giving an importance to this. So maybe, if you see that somebody is having a split of opinions in that particular family, you definitely go through the sessions with them. Have a joint session, do a fruitful debate, put forward your prognostications, because that is what they look up to, and that will not make them, kind of more disturbed, but then, it's going to help them take better decisions for their patients. That's all from my side, sir. Thank you so much.
Very, very important, Dr. Sanghamitra. That is what it is. As you said, once the time, you utilize your time wisely. Sri Priya, we can come out of the screen, Sri Priya. It's best utilization of time, I would say, because when you're already seeing the patient like this, many patients you'll see, any patient would have been there for some time, or might have been your own, like it might have been your regular patient, like we say, parent team who has been looked after by them. See, she's had a stroke before, so she would have been under the care of the neuro team for a long time. So you see how she is, how she was, and how is she progressing. Based on that only you prognosticate. You're not doing, as madam said, a very good, you're not what Jyotishwani, okay? You are only data, all data, and that. And any day we don't take any non-evidence-based decision at all. Even when someone is in ICU, you take the ICU chart, go over for 24 hours. You give for 24, 48 hours, 72 hours. From that first hour to that 72 hour, see all parameters. I say always, an anesthetist, so ABCD always. So go system-wise, see all system, what has improved, what has not improved. So in that 72, like this, I'm telling for ICU, but you do the same for all your patients, okay? Make sure you prognosticate and see how they're progressing. The same medication, is she getting better? No, with whatever I give, no change. So that are all evidence signs. So, and then you talk to the family with that. You don't talk to them without anything. You show them, we have given this, we have given that, but no response. Even antibiotic we have given, the white cell count is only going up. So like that, you have clear, no imagination there. Okay, then that makes you also comfortable. End of the day, in doing all this, I would say you also have a big role. How did madam start today's session? It all matters. So as your ethics is there, and you all have to look after yourselves also. When you make some decision and you're going to be not happy with the decision, it is not going to be nice for you. So we don't want anyone in that state. We want everyone to practice comfortably, effectively, efficiently, safely and satisfactorily. Okay, so that is what it is. So prognostication will be very helpful, and patient and family, oh, you have told us this is what it is, so we understand. We have all faced the situation. As she said, we have faced very difficult patients itself. I've had some who will totally, one family, nothing they agreed. So the son came separately and told me, you have to talk to my mother because my father was the patient. So then finally I had to speak to her, and then next day I had to send my team to go for home visit. And then the son called from there, and then the daughter called, and then she said, thank you. So it is matter of time, because I'll tell you one more statement. It is excessive love and affection is what is there, hidden there. Nothing other than that. Okay, no one is fighting there. It's the love expressed in different ways. So we also have to be careful dealing with it, and it can be done. Not that nothing can be done. Little bit of patience, little bit of practice, and doing it again and again. Everyone, all of you will become masters in it. That's all. Okay. Anything else is there in the chat? No. Anybody else has any burning question? Please do ask. If not, I will hand it over to you, Sri Priya.
Thank you, madam. Thank you, Madam Sanghamitra. Thank you for the nice inputs and good discussion on this, something which is very close to my heart also. Thank you.
Thank you so much.
Thank you. Thank you, Sanghamitra.
Thank you, Sanghamitra ma'am. It has always been a pleasure listening to your sessions, and each session is a guarantee, is a minimum guarantee when it comes to you. So thank you so much for joining us. And I should express my sincere gratitude to Dr. Swami, especially because I know that he is going through a hard time with an untimely demise in his family. And still he cooperated by sending his case presentation for today. Thank you so much, Dr. Swami, for that from my personal side. And thank you everyone for making today's session very much.
Thank you. Thank you for understanding.
Thank you, sir. Thank you everyone for joining in and making the sessions interactive. And we'll be continuing with another interesting topic and another eminent faculty joining in the next session. Till then, this is Sri Priya along with Dr. Sanghamitra Bora, Mr. Anup, and Dr. Ravita Venkateshan signing off from the Tips Eco Hub. See you in the next session, and please don't forget to leave your valuable feedbacks. Thank you everyone. Take care. Bye-bye.
Thank you.